Hello everyone, welcome once again to the continuous cardiac education program run by the UNMICRC Institute of Cardiology and Research Center. I am Dr. Divyakant Parmar, working as Associate Professor in Cardiac Anesthesia at UNMICRC. I am going to talk on neurological dysfunction after congenital cardiac surgery. The outline of my talk includes starting from introduction, pediatric brain development, clinical manifestations of neurological injury, mechanism of brain injury, then predictors of cerebral injury, neuroimaging studies, neuroprotective methods to prevent this, and lastly the conclusion. Let's start with introduction. Why neurological dysfunction is so much important for us? Despite the advances in surgical techniques, anesthesia management and the perfusion strategies, neurological dysfunction remains a significant morbidity for pediatric patients undergoing the cardiac surgery. It leads to poor outcome due to the increased ventilation and thereby increased hospital stay, and also leads to increased mortality. It is also associated with decreased quality of life and increased economic as well as social burden to the family. Its incidence varies from 2% to 25% as reported in the literature, but nowadays its incidence has been drastically reduced to less than 5%. Now, how this pediatric brain development is different in CSD patients compared to normal patients. Brain development starts at the 3rd week of gestation and continues till the early adulthood. So, during these periods, impairment of brain development occurs in more than 50% of patients with congenital heart diseases. Most of the patients, most of the syndromes with CSD have associated neurological abnormalities. Like in Down syndrome, patients have VSD or ABCD. Then in patients with HLHS, there is 30% incidence of brain dysgenesis, while many patients with chromosomal defects have associated preoperatively CNS abnormalities. Studies have found that there is a significant white matter injury present in these patients, and there is increased lactate level was found in the white matter tracts of these babies. Presence of abnormal circulation leads to decreased oxygenation in this patient that will insult the fetal brain development further. Apart from this, the presence of fetal hemoglobin impairs the tissue O2 delivery due to increased affinity for hemoglobin. Studies done on brain development in HLHS, TGA and single ventricle physiology found that the brain maturation is significantly reduced in these patients, making them susceptible to periventricular leukomalacia. Why these patients are high risk for ischemia and reperfusion injury? So, apart from the growth impairment of this pediatric brain, this developing brain has immature blood-brain barrier. They have impaired autoregulatory capacity and increased responsiveness to the inflammatory markers. Even old children are equally vulnerable to neurological injury due to long-standing uncorrected congenital heart defects. Studies done on neonates who undergo open heart surgery using CPB, they have found that their motor functions are weak compared to normal child who are not undergoing the CPB, and their sensory functions remains same. So, this finding will suggest that neurodevelopmental disorders may occur in later childhood, even in patients without cerebral damage. Coming to the clinical manifestations of brain injury. So, it may vary from severe life-threatening events to subclinical or silent damage, which may manifest as the child grows up. Among these, the major insults are seizure, stroke, hemorrhage, coma, chorioathetosis or brain death. There is increased chances of permanent sequelae after severe insult, and there is increased mortality in these patients. Minor trauma may present as hypotonia, transient neurological deficit, facial palsy, visual disturbances, and impairment in cognition, that is the memory, attention, focus, and speed of information processing. These patients may present later as behavioral and cognitive disturbances as well as developmental disabilities. So, many a time these patients not manifested perioperatively, but later on as the child grows on, we can found this abnormal findings. Coming to the neurological manifestations, these are the altered sensorium to unconsciousness, posturing, and seizure, and on CNS examination these patients have focal neurological deficit, plantar extensor, and may be unequal pupils. So, to daily neurological examination is essential to know the any neurological complication at an early stage, and for that sedation vacation is must in such patients. Among these, first one is the seizures. Seizures are the most common clinical manifestation of significant brain injury. Its incidence is highest during the neonatal period. If it present preoperatively, then it reflects the underlying brain dysgenesis, and if it occurs postoperatively, then it is associated with later development of severe cognitive sequelae. And if it is present perioperatively, then it is associated with the poor outcome, neurodevelopmental outcome. It may be related to acute metabolic abnormalities in pediatric patients such as hypoglycemia, hypocalcemia, hyponatremia, fever, or infection. So, this should be ruled out. Now, what are the clinical symptoms and signs of seizures? So, in this case, there is a change in mental status, myoclonic, tonic, or clonic motor activity occurs with change in vital signs. There may be abnormal eye movements, or there may be stereotype sucking or swallowing occur. It may be focal or generalized. In case of focal seizure, there is rhythmic sagging of an extremity associated with twitching of face or eye deviation. To subtle change in mental status may occur. In case of generalized seizures, there is whole body rhythmic sagging with loss of consciousness, with clenching of teeth, and secretions coming out from the mouth may occur. Sometimes there is only sign that is the episodic autonomic changes may occur when the patient is under relaxant or under deep sedation. Then there is sudden tachycardia and hypertension only occurs. That is the only sign of seizures. So, the risk factor in infants is DHCA time greater than 40 minutes, and that will increase the electrographic seizures in these patients. Coming to the delirium. So, what is delirium? It is the acute onset of cerebral dysfunction with 4 cardinal features. These are the fluctuation in mental status, decreased awareness or attention, and disorganized thinking. It usually occurs in critically ill children. Its incidence is around 21%, and it is assessed with Cornell assessment of pediatric delirium, and usually performed by the trained nurse in the ICU. So, there is a delirium picture set which consists of the various pictures of the animals, which is shown by the sister to the patient, and their eyeball reactions and the face expressions are noted, and from this sister can diagnose delirium present or not. The risk factors for delirium are the child less than 2 years of age, congenital heart disease, developmental delay, and baseline albumin less than or equal to 3 mg per deciliter, and the longer CPB time. The perioperative insults include the increased inflammatory mediators, alteration in neurotransmitters, subclinical cerebral infarction, and generalized hypoperfusion and hypoxia. All of these factors exacerbated by a prolonged CPB time. And lastly, the brain death. So, that is diagnosed by the absence of brain stem reflexes and by EEG documentation which shows no activity of brain. Coming to the mechanism of brain damage. The mechanism may be due to the hypoxia or hypotension, then embolism or infarction or hemorrhage. We will see one by one. First one is the hypoxic ischemic insult. So, cerebral ischemia can occur from reduced perfusion during CPB. It is general consensus that maintain a mean arterial pressure of between 30 to 50 millimeter of mercury while conducting CPB in children. But there is one study done in 54 children with an average age of 55 months, and they have found that the lower limit of cerebral autoregulation was 40 millimeter of mercury. So, we should keep the mean arterial pressure at least 40 millimeter of mercury or more during CPB. Secondly, many a times the perfusion cannot maintain the pressure, but he can deliver the full flows. But these full flows are not sufficient in a patient who is being perfused at mild to moderate hypothermia and is not fully dilated. So, the perfusion pressure should also be important for preventing the neurological injury in such cases. Equally, high perfusion pressure is also harmful for the brain, and because of the loss of the cerebral autoregulations. In case of oversized cannula for venous drainage in SVC is often neglected cause of ischemic damage to the brain. So, better to use small thin wall cannula with multiple side holes to promote cerebral venous drainage. Arterial cannula should be positioned in such a way that the arterial line pressure should not be high and there is no selective cerebral hyperperfusion, and all the arch vessels feel retrogradely from the cannula. In case of presence of MAPCA or the collaterals, in patients with significant bronchial collaterals, especially cyanotic patients, there is a significant left heart return and more than 25% of the pump flow can pass directly back to the left side of the heart. These collaterals tend to steal from the systemic circuit, leading to cerebral hypoperfusion, and so attempt must be made to coil this MAPCA before CPB in the cardiac catheterization laboratory. But if they are too small, then the left heart should be vented and pump flows should be correspondingly increased to maintain the systemic pressure and to prevent the brain damage. In case of deep hypothermic circulatory arrest, it can lead to cerebral ischemia if the circulatory arrest period is prolonged beyond the safety margin, that is 40 minutes at a temperature less than 18 degrees centigrade. So, DSC is performed in a complex congenital cardiac surgery like arch repair or IVC repair or very small kid with TAPVC. So, if this time limit is more than 40 minutes, then it can lead to cerebral ischemia, because the cerebral autoregulatory mechanism is hampered in this no flow state, will further add the ischemic insult. The adoption of alpha state strategy during DHCA, that will cause cerebral vasoconstriction due to the alkalosis, and that is further leads to uneven cooling of the brain, particularly the deep structures such as hippocampus and cerebellum. The Boston circulatory arrest trial depicts the short term and long term neurological issues in children undergoing DHCA. These are the low cardiac output syndrome, low brain maturation, hypotonia, hypertonia and cerebral palsy. Next cause is the embolism. Gaseous or the particulate microemboli can reach the cerebral circulation from open cardiac chambers or the CPV circuit. In case of arterial filter malfunction, particulate emboli reach the smaller end arteries in the cerebral circulation, that will lead to focal ischemia and cell damage. In case of gaseous emboli, may initiate inflammatory response in the vascular endothelium, leading to cerebral edema and further aggravating the insult. This cerebral emboli cause obstruction of capillary flow and thereby decrease cerebral blood flow, increase O2 consumption, and may result in subclinical neuronal damage even without evidence of stroke or significant impairment, and this will recover later on. In case of hyperthermia, while weaning of CPB, if aggressive rewarming done, then that will increase the metabolism and the O2 demand of the brain, leading to increased vulnerability to damage. Unrecognized cerebral hyperthermia may occur due to the proximity of the aortic cannula to the cerebral vessels and underestimation by the routine temperature monitoring probes, that is the nasopharyngeal probe and the rectal probe. So, it is sensed accurately only by a jugular bulb catheter or a tympanic membrane thermal record. So, this should be keep in mind. So, while coming off bypass, the temperature should be around 36 degrees centigrade for better neurological outcome. SIRS, that is commonly associated with cardiopulmonary bypass circuit, and it will lead to increased cytokine production in the plasma and the CSF levels, that is associated with post-operative encephalopathy and adverse neuropsychological disorders. Coming to the cerebral edema, that is caused by the global cerebral hypoperfusion, hyponatremia, or the SVC cannula displacement. It is not clear from studies whether edema results because of injury or injury leads to increase in ICP with global or regional decrease in cerebral blood flow and resulting ischemia. So, during CPB, cerebral venous pressure should be monitored more proximally in the SVC, and visual inspection of face should be done to detect this early. Now, hypoglycemia as well as hyperglycemia, both are harmful for the these pediatric patients. Blood glucose level outside the range of 50 to 126 milligram per deciliter for longer duration within 72 hours of cardiac surgery is associated with increased incidence of neurological injury, as this infant brain is exclusively depend for its metabolism on blood glucose, and this cellular glucose overload leads to oxidative stress and increased mitochondrial production of reactive O2 species, resulting in neuronal cell damage and brain edema. In case of low hematocrit, intraoperative anemia leads to reduced tissue O2 delivery, that is compensated by the brain with increased blood flow to the brain and higher O2 uptake. Under these conditions, cerebral injury can result from hypoxia or increased embolic load. The Boston trial has shown that a hematocrit of greater than 24% is associated with reduced lactate levels and improved psychomotor development scores. In our center, we usually keep the hematocrit around 30% on CPB. Coming to the stroke. Ischemic strokes are more common than intracranial bleeding despite the use of anticoagulant medications. Due to polycythemia in cyanotic congenital heart disease, there is increased risk of thrombotic stroke and brain abscess. In patients with ECMO, there is highest risk of stroke and other neurological complications due to the decreased cerebral perfusion, which leads to cerebral infarction or the hemorrhage or the cerebral hypoxia. Septic embolism may occur in 50% of patients with infective endocarditis and more commonly to the MCA territory. The sources, endogenous sources include the intracardiac, that is the prosthetic valve or the PTFE patch or the CVP line, and the systemic emboli such as DVT and pulmonary emboli. Hypercoagulable state secondary to cardiac disease and additional coagulation pathway abnormalities may contribute to this. Paradoxical embolism in which there is right to left shunting through the PFO or AST or the VSD may occur in single ventricle physiology or the TOP patients. Post cardiac arrest patients, the mechanism of brain injury is related to the time window of ischemia and hypoxia caused by the interruption of blood flow after cardiac arrest, and irreversible damage occurs when cerebral blood flow is completely interrupted for more than 5 minutes. After return of spontaneous circulation, brain experiences reperfusion injury causing the secondary injury. In our center, we usually start hypertonic saline 3% NS, maintain the temperature at around 35, then increase the mean arterial pressures, keep the patient sedated and paralyzed to prevent further damage. Now, low cardiac output usually associated with complex cardiac surgery, that is also responsible for neural injury by decreasing the cerebral blood flow and thereby cerebral oxygenations. Coming to the intracranial hemorrhage, which may occur in neonates who undergo bypass and receive anticoagulants or soda bicarbonate rapidly, and but this is very minor and resolves. Cyanotic CSD can result in polycythemia, hyperviscosity, thrombocytopenia, platelet function abnormalities, DIC, and abnormal fibrinolysis. Each of these abnormalities may increase the likelihood of systemic or intracranial hemorrhage. Now, anesthetic drugs is also associated with neurotoxicity. General anesthesia has been proved to be associated with prolonged behavioral disturbances in children, manifesting as prolonged crying, sleep disturbance, and anxiety. Studies have found that long-term neurological sequelae happen as cognitive impairment, low IQ, decreased vision, and hearing in children on follow-up. The long anesthesia time and multiple exposure to anesthetic agents are the risk factor for such neurodevelopmental problem. Which are the predictors of cerebral injury? Among these are the children with prematurity, perinatal hypoxia, cyanotic heart lesions, preoperative hemodynamic instability, mechanical ventilation, complex open heart surgeries, especially under DHCA, postoperative low cardiac output, use of ECMO and CPR. These are the candidates at high risk for neurological damage. Second is genetic predisposition is also attributed to neurological injury. And young age, complex malformation, metabolic acidosis, and increased lactate levels, these are the predictors of worse neurological outcome. Now, what is critical illness neuropathy? This usually we found in the critically ill patients, and when we do the CT scan or other radiological investigation, these are the normal, but and the patient have failure to wean the patient from the ventilator, and on examination these patients have symmetrical limb weakness, reduced or absent reflexes, but little sensory change, and wasting may occur, but it has good prognosis with recovery over 3 to 6 months. So, this is the axonal neuropathy which cause respiratory difficulty due to the peripheral nervous system problems in a patient with sepsis and multi-organ failure. It is mediated by the cytokines, and diagnosis require the nerve conduction studies which reveal the small amplitude compound muscle and sensory nerve action potential. On electromyography, it shows the denervation. On radio imaging studies, usually the radio imaging studies, the changes appear late. First is the CT scan, most commonly used investigations, but the sensitivity in detecting hypoxic brain damage is limited in the early stage, that is 24 to 48 hours, may be normal during this period. So, usually positive findings include the brain edema, loss of grey matter white matter differentiation, and effacement of deep grey matter areas. which may be late to appear. Then watershed infarcts may occur due to the hemodynamic instability or the embolism. These are the various images of the infarct. First one is the MCA territory infarcts on the left side. Second is the air embolism. Third one is the watershed infarcts that occur at the junction of two arterial at the junction of the two arterial supply, and as previously mentioned, occur due to the hemodynamic instability. And last below one is the lacunar infarct of the left thalamus. MRI that is the most ideal investigation to detect even minute changes immediately after a suspected neurological insult, but it is very costly and usually not available everywhere, and many a times it is difficult for shifting of the patients for MRI, as it takes more time compared to CT scan. And third one is the ultrasound of brain. So it is useful for diagnosis of intracranial hemorrhage in neonates, especially in premature infants, and it should be used daily for first 5 days on ECMO. Coming to the neuro monitoring, under anesthesia usually all the vital organs are monitored, but the CNS is the least monitored organ, and that is why it leads to grave post-operative complications. If it monitored in high risk population correctly, then it leads to good neurological outcome. Various modalities are available. Among these, first one is the NIRS, that is the near infrared spectroscopy. In this there is a sensor with adhesive pads applied over the forehead, and this sensor consists of one is the light source and other two detectors, in which the shallow detector detects from the superficial tissue, that is the scalp and superficial tissue, while deep detector detects from the deep tissues of the brain. So the principle is that by using multiple wavelength of near infrared light, absorption of this light by oxygenated and deoxygenated hemoglobin determines the overall saturation of blood present within the brain tissues. It measures both arterial and the venous blood oxygen saturations. The normal regional saturation in a cyanotic patient is around 70%, while in cyanotic patients it is around 40 to 50%. So first baseline saturation is recorded, and then if it is 20% decrease from the baseline, then it is a very important change, as it is associated with the poor neurological outcome. It can be increased due to the during DHCA, as there is decreased O2 utilization, and due to the hypercapnia, which lead to cerebral vasodilatation and increase FiO2. It decreases during the hemodynamic instability due to the decreased cerebral blood flow. Then SVC occlusion, this is very important, as whenever SVC cannula is partially or the completely occluded, then rest of the parameters like arterial blood pressure, heart rate, central venous pressure, all are not changed. Even mixed venous saturation is also not changed. So, but NIRS shows the cerebral desaturation. So that is only a modality that will diagnose this SVC occlusion. In case of hyperventilation, that will cause decreased PCO2 and respiratory alkalosis, that will cause cerebral vasoconstrictions. Only limitation of this is that it measures only a small tissue volume of frontal cerebral cortex, while other areas of cortex and deeper structures in the brain are not assessed. Other potential uses are measuring oxyhemoglobin saturation in kidneys and intestines. This is the flow chart of cerebral desaturations. If it occurs unilateral on the single side, then first verify the head position, make it neutral. If it occurs bilateral, then first check for the sensor connection, or if not proper, then replace it or reposition it. Then still desaturation present, then check for mean arterial pressure. If it is low, then optimize cardiac output by manipulating stroke volume and heart rate, and it is okay, then assess for the SVR. Then if mean arterial pressure is normal, then check for SaO2 divided by PO2 ratio. If it is low, then treat and find the etiology, and if it is normal, then watch for PaCO2. If PaCO2 is low, then correct hyperventilation. If PaCO2 is normal, then check for cerebral O2 consumption. The factors which cause increased O2 like convulsions, sepsis, hypothermia, inadequate anesthesia, and according to treat this. If normal O2 consumption, then check for venous O2 saturation. If it is low venous O2 saturation, then optimize oxygen consumption and delivery. And if it is normal, then check for hemoglobin concentration, and if it is low, then consider transfusion. So we can correct the various factors from this flow chart. Last one, that is the transcranial Doppler. It is a real-time non-invasive investigation which is used for the diagnosis of cerebral vasospasm by measurement of blood flow velocity. If mean velocity is less than 120 centimeter per second or peak velocity greater than 200 centimeter per second, then it is significant. It monitors middle cerebral artery through the temporal window, which can be found just above the zygoma and just anterior to the tragus of the ear, as shown in the figure. The emboli are easily detected by transcranial Doppler, although false positive artifacts from electrocautery and physical contact with the ultrasound transducer may occur. True emboli have characteristic audio and visual signals, that is the high intensity transient signals, which requires further complete de-airing from cardiac chambers. Now, it measures cerebral blood flow velocity rather than blood flow. So, changes in cerebral blood flow velocity correlate well with changes in cerebral blood flow in the individual patient, particularly at deep hypothermia when autoregulation is lost and diameter of vessel unchanged. So, the cerebral blood flow velocity correlate well with the blood flow in such patients. It is also used to determine the threshold of detectable cerebral perfusion during low flow CPB, that is around 30 ml per kg per minute during DHCA. It can detect acute decreases in cerebral blood flow velocity, which can allow for adjustment of venous cannula, especially the SVC cannula, and it is diagnosed by slowing of diastolic flow velocity on the Doppler. Coming to the jugular bulb oximetry, it is the very old method for monitoring of cerebral oxygen saturations, in which there is percutaneous sampling of cerebral venous blood done, and the concept behind this is that the arteriovenous differences between oxygen, glucose and lactate has been done, which has been proposed as a global measure of the balance between cerebral metabolic supply and the demand. This image shows that the catheter should be introduced into the IJV, same as we introduce the central line into the IJV, but in a retrograde manner, and it is advanced cephalad till the filling of resistance at the jugular bulb, and then the catheter is withdrawn 0.5 to 1 centimeter, so that it does not lie against the roof of the catheter bulb. Correct catheter placement is at the level of Mustard process and it is confirmed by lateral X-ray. The normal saturation is 60 to 70%, and if it is less than 50%, then cerebral dysfunction may occur, which should be treated with inhaled CO2, carotid shunts, or increase in mean arterial pressures. This jugular blood desaturation is commonly occur in 25% of patients during rewarming from CPB, because these periods of increased O2 extraction in relation to flow are associated with greater post-operative cognition dysfunction. It is reduced jugular venous saturation occur in case of low PaCO2, hypoxia, hypotension, anemia, and the vasospasm. While elevated saturation, that means greater than 75%, occur in case of increased PaCO2, hyperemia, brain death, or infarction. In brain death and infarction, the brain utilizes minimal oxygen, while in hyperemia and increased PaCO2 there is increased cerebral blood flow that will lead to increased saturations. Limitation of this jugular venous oximetry is that only small area of ischemia is not detected, and all the complications related to central line, while false sampling or error in sampling may occur due to the catheter kinking or the catheter displacement. Coming to the EEG, electroencephalogram, like the ECG, it will measure the that is the electric activity of the cortex, and it uses the 2 to 16 channel, and it measures the excitatory and the inhibitory postsynaptic action potential. It is a definitive test to detect seizures and quantify their frequency, predict future seizure risks and neurological outcome. Video EEG is helpful to determine or clinically suspicious movements, behaviors, or autonomic changes are a sign of seizure activity or not. It helps in guiding the anesthetic depths. It is useful for anesthetics during DHCA if further cooling is required or not for initiation of DHCA. For the diagnosis of brain death, as there is no brain activity in brain death, it is affected by factors like anesthetics, temperature, and CPB. So, limitation of the EEG is that it requires dedicated technician to place the electrodes and interpret the EEG. So, it is not recommended routine use in infants and children undergoing pediatric CPB, as abnormal readings on the EEG did not appear to correlate with adverse post-operative outcomes. Now, neuroprotective strategies. So, these strategies, if used correctly and carefully, then we can prevent neurological complications and protect the patients from neurological sequelae that may be permanent, as there is no treatment for this neurological complications, and treatment is only palliative. While worse neurological outcomes have been reduced from 25% to less than 5% over a decade by adopting newer neuroprotective methods and modified bypass strategies. So, optimizing these bypass strategies. Among these, first one is the hyperoxic versus normoxic CPB. Usually these cyanotic patients are chronically adapted to the hypoxia. All the organs are adapted with the low PO2. So, these patients are susceptible to the damaging effects of a sudden rise in arterial O2 tension that may occur following initiation of CPB. So, there is excessive release of O2 free radicals which can damage the myocardium, kidney, or brain. This may lead to significant neurological deficit. So, while initiating CPB, ensure that PO2 remains in the 90 to 100 millimeter range and hyperoxia is avoided. The only condition where hyperoxic bypass is clinically proven to be beneficial in cyanotic children is while using DHCA. Here hyperoxia is shown to limit the neuronal damage. Coming to the DHCA, that is the deep hypothermic circulatory arrest. There is a Boston circulatory arrest trial was performed, and they have advised some modifications in this technique. Among these are the first one is the increasing the on pump hematocrit value for the better oxygen delivery, TCO2 delivery. Then second is intermittent perfusion during DHCA has shown to improve the neurological outcome. Another preferred option is to adopt a crossover strategy. While adopting profound hypothermia, the CPB is initiated with alpha state strategy, and 10 minutes before inducing profound hypothermia, switch on to PS state strategy. This is thought to produce cerebral vasodilatation and increase the blood flow for uniform cooling of the deep brain structures. Again, while on DHCA and while coming off CPB, alpha state method is restored. Right. So, in short, 10 minutes before DHCA, PS state strategy, so that will increase PCO2, that will lead to cerebral vasodilatation for the uniform cooling of the deep brain structures. The safe duration of arrest has been proved to be a maximum of 40 minutes. So, greater than 40 minutes is associated with poor neurological outcome. Low flow cardiopulmonary bypass, the full flows in a child are maintained at about 100 to 150 ml per kg per minute. It may not be safe to perform the procedure under low arterial flows at 50 ml per kg per minute or less, as it may not necessarily protect the brain from hypoperfusion. So, under these conditions, neurological monitoring should be employed to avoid inadvertent damage to the brain. Antegrade cerebral perfusion, as a part of efforts to avoid DHCA, antegrade cerebral perfusion through the arch vessels was developed. This was thought to provide good bloodless surgical field as well as provide cerebral oxygenation. Studies have found that better results with ACP when the flow rates were kept at mean of 64 ml per kg per minute. Emboli reduction, this study was done in 2002, and they have found that after drug injections into the venous reservoir, gaseous emboli can make a rapid passage to the arterial outflow. Reducing these perfusionist interventions reduce gaseous emboli generation and neurocognitive impairment. Blood that is returned from the surgical field through the use of the cardiotomy suction may significantly contribute to the particulate load in the CPB circuit and then brain. The use of cell salvage devices to process this shed blood before returning to the venous reservoir may minimize the amount of particulate or lipid laden material that contributes to embolization. But the disadvantages are that it reduces the clotting factors and cost is also a factor with utilizing this cell saver devices. Hypothermia in therapeutic levels. In DHCA, profound hypothermia is done that lead to cerebral vasoconstriction, which elevates the cerebral vasoresistance and abolishes the autoregulatory capacity of the brain. If we perform hypothermia at therapeutic levels, then it offers protection by maintaining autoregulation and responsiveness of cerebral vasculature to CO2. So, when the core temperature was lowered to 33.5 to 35 degrees centigrade post cardiac arrest for 72 hours, then neurological damage reduced to 30 to 40%. So, this hypothermia will prevent the secondary injury. permissive hypercapnia. An early meta-analysis of moderate hypercapnia in newborn infants demonstrated decreased intraventricular hemorrhage, although it is not significant. Hypercapnia may be protective to the immature brain in whom raised intracranial tension does not contraindicate an increased PaCO2. Various drugs utilized for neuroprotection. Among this, first one is the dexmedetomidine. In the recent trial, it has been found to be neuroprotective role and also effective in reducing the neurotoxic effects of drugs such as isoflurane. So, it can be used as a sedative drug or the infusion in post-operative pediatric patients. Then phenobarbital, it is one of the first agents investigated as a potential neuroprotective agent for cardiac surgery, and it is also used as an anticonvulsant. Steroids have always a controversial role, and there is limited evidence to suggest that steroids are beneficial, as it may cause the hyperglycemia that will lead to poor neurological outcome, but due to its anti-inflammatory property, steroids are still being used and helpful in reducing the post-operative neuropsychological disorders and brain injury. In one study done in 1986, thiopental was administered until EEG isoelectricity was obtained before cannulation and continued until separation from CPB. They have found that neurological complications were significantly reduced in these patients. The mechanism behind this is that it caused cerebral vasoconstriction, leading to decreased cerebral blood flow and decreased embolic load. But the disadvantages are prolonged recovery, delay extubation and hypotension requiring inotropic support. So, finally, to conclude the neurological dysfunction, neurological monitoring should become routine during congenital cardiac surgery, and it should be multimodal approach. The greatest benefit will be long-term neurodevelopmental outcomes, which are difficult to quantify but important for patients' quality of life. Thank you.